Okay, so now some basic pharmacokinetics and pharmacology concepts. The pharmacokinetics are absorption, distribution, metabolism, and excretion. How does the medicine get into the bloodstream? How does it get to where it's supposed to work? How is it metabolized, and then how is it excreted? So absorption is getting the drug into the bloodstream. And there are a few drugs that actually don't enter the bloodstream. They're not absorbed. They are intended to act locally wherever they're administered. But typically, most drugs we want to get into the bloodstream. That can be passively by diffusion. That's typically fat-soluble drugs. That can be active that in a way that requires a carrier. Pinocytosis is when cells in the gastrointestinal membrane engulf the molecule and transport it to the bloodstream. So there are different methods. Now, you don't really need to stress too much about how each med is specifically transported into the bloodstream. What you need to know is what can affect that. So you need to have heard of those methods, because then the things that can affect that absorption will make more sense to you. So what are the things that can affect medication absorption? Blood flow. If I give someone a subcutaneous medication and they have poor perfusion, maybe they're really constricted peripherally because they're in shock or because they're hypothermic, that med is not going to be absorbed consistently. That may not be absorbed at all for now. So blood flow, perfusion. If they take something through the GI tract and they're not perfusing their GI tract, they're not going to get that med into their system. Pain can affect absorption because pain can cause vasoconstriction or dilation. Stress, hunger, food. If I take an oral medication, food is usually going to slow down the breakdown and absorption of medications. Some medications cause a lot of GI irritation, and so the patient takes them with food, but we know that slows down the absorption. The pH, most meds need to break down in an acidic environment, and so if gastric pH is too high, they may not break down enough to be absorbed. That's why we don't typically want to give antacids to raise that pH of the stomach along with other meds that we want them to absorb, because that's going to affect the absorption. And then peristalsis. Most things are absorbed in the small intestine. So if our patient is moving things through their intestine too quickly, they may not have time to absorb it. Okay. Bioavailability is a term that refers to the percentage of the drug that reaches circulation. So absorption is getting the drug into the bloodstream. Okay. Distribution is getting the drug to the target tissues. Now the drug is in the bloodstream. I need that antibiotic to get to my infection in my brain. Well, only some things cross the blood-brain barrier. Not everything can get into the brain. So specific meds are chosen for central nervous system infections that can cross the blood-brain barrier. Or I take a medication and I need it. I need that antibiotic, or I need that something to get to my kidneys. Okay. I need something that's going to affect my kidneys. Maybe I'm taking Lasix. If I'm not perfusing my kidneys, the Lasix is not going to get there to work on the loop of Henle. So perfusion affects distribution. It affects absorption. It also affects distribution. The drug's affinity to tissues. So some drugs are more likely to enter certain types of tissues. And another is protein binding. Now, I want you to think about protein binding for just a second. Okay. We're going to look at the whiteboard, and you get to laugh at my terrible drawing. Let's say here's my vascular system. Okay. It's a very simple vascular system. Okay. And I have protein molecules. Okay. Here is Mr. Smith's vascular system. And he's got fewer protein molecules. Maybe because he hasn't been eating well. Okay. Okay. If I take a medication that is highly protein bound, let's just say I take digoxin because it's highly protein bound. And let's say that the amount of digoxin I take is based on okay. So the amount of digoxin I take is going to put 10 molecules in this particular segment of my bloodstream. Okay. All right. Now, the only digoxin that works is the free digoxin. So for me, this is how much free digoxin I have in my bloodstream. Okay. And let's say that's a therapeutic level. Mr. Smith, who doesn't eat well and isn't feeling well, this is how much free digoxin he has in his bloodstream. Let's see if we can circle all of them. So he's got 3 times as much free digoxin roaming around in his bloodstream as I do because he has that much less protein. So if this is a therapeutic level of digoxin, this is toxic. Okay. So if a medication is highly protein bound, that means that the proteins in our bloodstream bind with a lot of the molecules of that medication. And only the molecules that are left unbound are actually effective. Dosing is based on that. Dosing is based on losing part of that medication, losing some of the molecules of med to protein binding. So if we have less protein than typical, we end up toxic. Okay. So now let me undo my circles. And I'm going to undo. Now we're going to go back just to me. This is how many proteins I've got sitting around. And I'm taking digoxin, but I'm also taking another medication. We'll just call it medication X. That's also highly protein bound. Okay, so that's 1, 2, 3, 4 of each. So now I've got all this much digoxin and medication X left over. Now, they may not bind evenly. If the digoxin comes in and medication X is all bound to most of the protein, I may have even more digoxin free and less of medication X, or vice versa. They compete for those binding sites. Okay. So that means I can be toxic on either one of them. So when we talk about distribution, we've got to also consider protein binding and how much of that medication is actually free in the body. Okay. So we've talked about absorption and we've talked about distribution. Now we have metabolism. Most drugs are taken in their active form. We take the med and it works in the body as it enters the body, and then it has to be metabolized to a form that doesn't work. Okay. Lipid soluble drugs have to be converted by the liver to a water soluble form for excretion. Now, when that med, if that med is not metabolized well, then it just stays in the body, in the bloodstream, and it builds up. So let's say we have a lipid soluble medication and the patient has, most meds are metabolized in the liver. The patient is in liver failure. They're going to have more and more and more and more of that drug in their system because their liver is not working to metabolize it. So that's one issue with metabolism. Another is that sometimes medications are transformed to something else that is active in the body. So meperidine, when it is metabolized, one of the metabolites is called normeperidine, and normeperidine is excreted, but it's excreted slowly. So if someone takes meperidine for more than like 3 or 4 days, they can build up enough normeperidine, that byproduct, especially if they don't excrete it well, they build up normeperidine and can develop some side effects from that. Now, the side effects of normeperidine are hallucinations and delusions. And I've seen that occur once, and it was nursing that figured out the patient had been on Demerol for 3 days, convinced the resident to change the order. They were actually getting a psych consult. Convinced the resident to change the order, and the patient's psychosis resolved. So just stick that in the back of your head. You ever have a patient on meperidine, which is not used as much as it used to be. It's barely used anymore, but I've been a nurse a long time. Ever have a patient on meperidine and they start getting psychotic symptoms, think about holding that meperidine and changing it to another med. And that doesn't occur with other opiates. It's a specific thing to meperidine. There's one other thing that you need to understand about metabolism. Some meds, we take them and they're not in the form that we want them in. So they go through the liver and they're metabolized, and that's the form that they're active in, and then they are metabolized again and excreted. Or they're maybe metabolized, they're active, and then they're excreted. That's so if that's the case, if the med doesn't work until it's been metabolized, if they don't have a functioning liver, that med will never work for them. Okay, so metabolism mostly is affected by liver function. Excretion is getting the drug out of the body. Most drugs and metabolites, drugs and whatever they metabolize to, out of the body. Most drugs are excreted by the kidney. Some are excreted in the GI tract, saliva, sweat, lungs, and breast milk. The half-life refers to the time it takes to eliminate half of the drug. After 5 half-lives, the drug is considered to be eliminated from the body. So get a drug book, look up what is the half-life of morphine. And I don't actually have my drug book here, so I'm going to pull out my handy dandy pocket computer. Okay, I'm going to look up half-life of morphine. Let's see, 2 to 4 hours. Okay, so in 2 to 4 hours, half of that morphine dose is gone. In another 2 to 4, half of what's left is gone. So if you give 10 milligrams of morphine, that's a whole lot. I have given that much to cancer patients. 2 to 4 hours, 5 of it's going to be gone. 2 to 4 hours after that, there'll be 2.5 left. 2 to 4 hours after that, there'll be 1.25 left. 2 to 4 hours after that, then it should be eliminated. It's considered eliminated. Okay. Now let's look up the half-life of naloxone. "60 minutes. Okay, can range from 30 to 90. So you see where I'm going with this? If I'm supposed to give the patient 1 milligram of morphine and the concentration is not what I thought it was, and I accidentally give 10 milligrams of morphine and they have respiratory depression, that respiratory depression can last for several hours. The half-life is 2 to 4 hours. So we're looking at up to 20 hours. So probably between 10 and 20 hours of sedation. Now, the first part of that, the first 4 or 5 hours, they may have respiratory depression, right? So I give that Narcan. Narcan's eliminated in 5 hours. So our patient may still have respiratory depression when the Narcan is no longer, the half-life is an hour, half-life of morphine is 2 to 4 hours. So our patient may improve with Narcan. Narcan is metabolized and excreted. Morphine's still there because it's slower. So they may go back into respiratory depression. Okay, so be aware of half-life. Half-life is the time it takes to eliminate half of the drug. A lot of meds are dosed based on half-life. If a medication has a half-life of 36 hours, it might be given once a day, but it may take 2 or 3 days to get to the level you want. Okay, it might be given because that level depends on having a long half-life and adding a new dose to get to the level you want. If a med has a short half-life, it's going to be given several times a day because it's not going to last. It's going to go away. So half-life affects dosing. Another concept you need to consider is onset, peak, and duration. When does a medicine start working? When does it have peak effect? How long does it last? Which is connected to half-life. When you look at receptors, a lot of medications attach to receptor sites on body tissues. And so we need to be aware of whether they are agonist or antagonist for those receptor sites. So thinking back again to opiates attach to the mu receptor, and that's an agonist for the mu receptor. It causes sedation, decrease in pain perception, decreased respiratory effort, etc. Right? Naloxone also attaches to the same receptors, and it is an antagonist. So it reverses all of those things, and it blocks the opiate from being able to connect to it. Okay, so agonist versus antagonist, selective versus non-selective. When we talk about especially drugs that affect the adrenergic system, there are different types of receptors, and we want to look at whether a medication triggers or blocks one type of receptor, so it's selective, or all of the types of receptors for that particular system. So it'd be non-selective. So we look at beta blockers in particular, or at some asthma meds, those adrenergic agonists. Therapeutic range is the range between enough to work and enough to be toxic. Okay, we want meds to be therapeutic, so they have to have enough to range or to work. We don't want them to be toxic. Some drugs have a really wide therapeutic range. Some drugs have a very narrow therapeutic range. So if something has a narrow therapeutic range, especially if the toxicity is particularly dangerous, we're probably going to be monitoring levels of that frequently. Think about digoxin is one with a narrow therapeutic range. We should be monitoring digoxin levels because there's not a lot of space between doesn't work and toxic. We've got to get in that space where it works, but it's not toxic. Okay. Mechanism of action. This is one of the most critical things you need to understand when you're studying any new medication, and you will run into new medications for your entire career. When you are learning a new medication, what you want to know is what does it do in the body? And now, as a practicing nurse, probably the best way to understand that is physiologic. You can get into chemistry, but think about physiologically, what does this do in the body? When we talk about diabetic meds, we're talking about oral anti-diabetics. There are medications that we give for diabetes that trigger the body to produce more insulin. There are medications that we give for diabetes that decrease insulin resistance, make the body's tissues more receptive to insulin. Okay, now, if we're giving, which one of those meds would you think, if we can give either, which one of those meds would you think is more likely to cause hypoglycemia? It's going to be the one that triggers insulin production, right? So understanding the mechanism of action is the key to understanding not just what this medicine is supposed to do for your patient, but also what side effects and adverse effects and risk you need to monitor for as a nurse. Side effect, adverse effect, toxicity. A side effect is expected, common, can be uncomfortable, can be serious or severe enough or uncomfortable enough that people will stop taking the medication, but they're not considered dangerous typically. So think about a side effect of vasodilating medications is orthostatic hypotension. That's something we expect to occur. We can teach patients about that and teach them how to accommodate for that, and teach them that if it's too serious, too bad, too severe, they need to talk to their provider about changing that prescription. An adverse effect is unanticipated, usually a little bit more serious. So think about someone taking a statin. A potential adverse effect of that is oh, it just flew out of my head. Muscle breakdown, rhabdomyolysis. Okay, that's not an effect we want to teach our patients to live with. And then toxicity is what happens when your level of that medication is too high. So think about dig toxicity can cause nausea, vomiting, green halos, but also it can cause a really, really slow heart rate that we don't want to happen. Tolerance is when someone's body is becomes tolerant to or adjust to a medication and requires increasing amounts of that medication to get the same effect. Tolerance occurs with a lot of meds. We hear about it a lot with opiates. Patients who take opiates routinely require higher doses of opiates to get relief in an acute situation. And that's because of tolerance. The placebo effect is when something works because we think it will work. Drug interactions. There are several types of drug interactions you need to be aware of. Synergistic is one. That's when two meds have the same or similar effect. And when you take them together, the effect is not just doubled, but can be multiplied or even exponential. Antagonistic is when one med is working against another. There are drug and nutrient interactions. There are specific nutrients that affect the absorption of drugs or that make drugs more active. There are drug lab interactions. That means that there are some medications that will actually alter lab results, and we need to know the patients on that med when we interpret the lab results. And there are drug-induced photosensitivities. There's some meds, like tetracycline, that if someone's taking it, if they're in the sun, they have increased photosensitivity. Pharmacogenetics is an area that's still being studied, but there are some genetic differences in the way people absorb, distribute, metabolize, and excrete medications. And some developmental considerations. Pediatrics, okay, kids and meds are weird. You can't just make the dose smaller based on the kid's size. Sometimes they do that, but it has to be done very carefully. Not a lot of research has been done for some meds with kids. More common meds, some has been done, but they're not just smaller adults, okay? They may absorb, metabolize, and excrete either more rapidly or more slowly. Yeah, I know. So medication doses for pediatrics ideally should have been tested in pediatric patients at some point. Some things have not been, and those need to be monitored more closely. Geriatric patients, all of those pharmacokinetics may slow down. Also, geriatric patients are more likely to experience polypharmacy. They have prescriptions for some things. They may even have prescriptions for the side effects of other prescriptions. They go to a different doctor and they have a different symptom, they add on. It's common for people to add on prescriptions for elders. And so they end up taking a lot of pills and having a lot of side effects. Polypharmacy is actually a common contributor to patient falls. Okay, we're going to come back in the next sections and talk about systems. In each system, we're going to talk about a few classes of medications. This is nowhere near exhaustive, but some classes that you need to be aware of and familiar with. So when you go into the clinical setting, if you haven't seen them before, you've at least had some exposure to them.